Okay, so for today's agenda, we are covering 6 quick sections: introduction and framework, the grading table, clinical management, exam pearls, an interactive MCQ drill, and finally, a Viva Voce simulation. Let's get to it.
Section 1. Introduction and Framework. Understanding the why.
So the crucial point to understand right off the bat is that the ASA classification evaluates a patient's systemic health baseline. It's there to estimate their preoperative physical fitness and predict perioperative morbidity and mortality. But, and this is a huge but, what it unequivocally does not do is assess the technical difficulty of the surgical procedure itself. A massively complex surgery on a totally healthy patient, that doesn't change their ASA score one bit. Really make sure you remember that distinction.
Moving right along to Section 2. The grading table, core framework.
Now, the ASA system basically categorizes patients on a spectrum. Up at the very top, we've got ASI 1. This is your completely healthy patient, like a young adult with zero systemic disease. Then ASI 2 introduces mild systemic disease without any functional limitation. Think of a patient with controlled hypertension, or maybe a patient who is pregnant or smoker. ASI 3 steps it up a notch to severe systemic disease with significant functional limitation, so poorly controlled diabetes or a previous myocardial infarction. ASI 4, that represents severe systemic disease that's an actual constant threat to life, like unstable angina or decompensated heart failure. ASI 5 is the moribund patient. They really aren't expected to survive without the surgery. A ruptured abdominal aortic aneurysm is a classic example here. And lastly, ASI 6 is reserved strictly for a brain-dead patient undergoing organ donation.
All right, Section 3. Clinical Management. From Theory to Practice.
You'll notice how clinical management shifts really dramatically as we move down that list. For ASA classes I and II, patients are generally highly suitable for elective surgery after just your routine prep. But once you hit ASA 3, you really need to pause. You've got to optimize those comorbidities before wheeling them into the OR if at all possible. By ASA 4, we are talking essential surgery only, and it requires intensive perioperative monitoring. ASA 5, that's an absolute life-saving desperation move despite extremely high risk. And of course, ASA 6 is purely for organ procurement.
Now for Section 4, high-yield exam pearls, avoiding examiner traps.
Examiners absolutely love to test the nuances here. Notice how a single disease state can change grades based entirely on clinical control. Hypertension is the classic trap. If it's well controlled, boom, that's just an ASA 2. But if it's uncontrolled and causing end-organ effects, that immediately jumps to a Class 3 or 4 depending on the severity. It is all about functional limitation and whether it's a threat to life.
Let's lock in a few more vital modifiers. You should memorize these points for sure. First, emergency status always adds the suffix E to whatever the base grade is. Second, age alone never determines the ASA grade. A totally healthy 90-year-old, still an ASAI. Also, pregnancy automatically makes an otherwise completely healthy patient an ASAI. And I'll say it again for the folks in the back. The ASA score predicts anesthetic and surgical risk, not surgical difficulty.
Okay, Section 5. Let's do an interactive MCQ drill.
Question 1. A healthy 25-year-old man is scheduled for an elective inguinal hernia repair. Is he A, ASA 1, B, ASA 2, C, ASA 3, or D, ASA 4? Read the vignette carefully and lock in your answer for this healthy 25-year-old.
Well, if you chose A, you are spot on. Since he has absolutely no systemic disease mentioned, he perfectly fits the baseline criteria for ASAI. The hernia itself doesn't bump his systemic grade at all. So your exam pearl here is simple. A healthy patient always equals ASAI.
Question 2. A patient with well-controlled hypertension is planned for an elective laparoscopic cholecystectomy. Are they A, ASA 1, B, ASA 2, C, ASA 3, or D, ASA 4? Think about how the presence of well-controlled hypertension alters this patient's physical status.
And the correct answer is B, ASA 2. It bumps them up because they do have a systemic disease. But because it's well controlled and carries no functional limitation, it hard caps at Class 2. So the key takeaway? Controlled disease without functional limitation caps at ASA 2.
All right, question 3. A patient with decompensated heart failure requires an emergency laparotomy. Are we looking at A, ASA 3E, B, ASA 4E, C, ASA 5E, or D, ASA 2E?
Pay really close attention to both the severity of the condition, it's decompensated, and the urgency of the surgical procedure, which is an emergency.
The correct choice is B, ASAIV. Decompensated heart failure represents severe systemic disease that is a constant threat to life. So that gives us our Roman numeral 4. And because the laparotomy is an emergency, we just append that E modifier right at the end.
Section 6. Viva voce simulation.
Picture this. You're in your oral boards. The examiner looks at you over their glasses and asks, "Candidate, what exactly does the ASA classification assess?"
You want to deliver a concise, model answer. You say, it assesses preoperative physical status and perioperative risk. Boom. You demonstrate immediately that you understand it evaluates the patient's biological fitness.
Then, the examiner nods and follows up. And does the ASA grade depend on the type of surgery being performed? Now, this is a direct test to see if you're going to fall for the most common medical student misconception.
No, it depends on the patient's systemic health, not the procedure. You make it totally clear that surgical complexity has absolutely zero impact on the ASA score.
Finally, the examiner gives a rapid-fire follow-up to test your knowledge of clinical modifiers. Finally, what does the suffix E mean?
Emergency surgery. That's it. A quick, simple, and direct confirmation is literally all that's required to pass the station with flying colors.
So, you've completely mastered the ASA physical status classification. But to wrap up this explainer, I want to leave you with a thought. If the ASA score perfectly predicts a patient's baseline risk coming through those double doors, what hidden variables on the operating table actually dictate mortality that we still need to learn to account for? Think about that the next time you scrub in. Thanks for joining me on this explainer, and keep learning.